Hello friends, today we are going to discuss about myasthenia gravis. So myasthenia is an autoimmune that affects the neuromuscular junction. It is treatable disease but can result in significant morbidity and even mortality. This can be usually prevented with timely diagnosis and appropriate treatment of the disease. The age of onset is variable from childhood to late adulthood, with the disease peak in young adult women and older men. Myasthenia gravis is the example of antibody-mediated autoimmune disease. It can also be viewed as example of class 2 hypersensitivity reaction, as IgG autoantibodies react with intra-extracellular antigen, leading to end organ damage. Crisis refers to threatened or acute respiratory compromise in myasthenic patient. It may reflect the respiratory muscle insufficiency or inability to handle secretions or oral intake. Regarding pathogenesis, myasthenia gravis is an autoimmune disorder of neuromuscular transmission. Circulating antibodies react with the component of acetylcholine receptors within postsynaptic muscle membrane and activates complement-mediated lysis of muscle membrane, accelerate receptor degradation, and impair receptor activation. That is, it interfere with the normal receptor activation by acetyl. The result is fewer receptors that can be activated at affected neuromuscular junction, causing weaker muscle contraction. Electrophysiologic study of the myasthenic neuromuscular junction discloses end plate potential that are diminished in amplitude. So this is the pictorial representation of neuromuscular junction in normal patient and in neuromuscular junction in myasthenia gravis patient. So the diagram A is representative as neuromuscular transmission in a normal patient, and in diagram B is representative of neuromuscular transmission in myasthenic patient. So there is decreased density. So in the diagram B, there is decreased density of acetylcholine receptor and complement-mediated damage to postsynaptic membrane in myasthenia gravis patients, resulting in decrease in miniature entry potential, which occurs with spontaneous release of acetylcholine receptor vesicles, as well as end-plate potential in response to nerve action potential of presynaptic membrane. So there will be the diminished amplitude of end plate potential in myasthenia gravis results in impaired neuromuscular transmission. Now, causes of myasthenia crisis. Myasthenia crisis is most commonly precipitated by the infections. The most frequent are respiratory tract infection caused by viral or bacterial agent. The aspiration pneumonia occurs in about 10% of myasthenia crisis patients and may be more prevalent in patients with oropharyngeal weakness and are manifested by the difficulty in swallowing, chewing, altered facial expression, and disarray. Certain medication exacerbates myasthenia gravis leads to myasthenia crisis. Other factors which lead to myasthenia crisis include botulinum toxin injection, recent surgical procedures such as thymectomy and trauma. The presence of thymoma seems to be the risk factor for myasthenia crisis. Hypoalbuminemia upon hospital admission has been associated with more severe myasthenia gravis and myasthenia crisis. Several risk factors have been described for postoperative myasthenia crisis include following: alcohol consumption prior to surgical procedure, postoperative complications like atrial fibrillation, pneumothorax, and acute respiratory distress syndrome. Regarding clinical spectrum, the clinical hallmark of the disease are weakness and exaggerated muscle fatigue. The specific muscles involved and the specificity of the weakness are highly variable between individuals and within the same individual over time. Ocular muscles are more frequently involved, diplopia is common, and various patterns of ophthalmoparesis are seen. Bulbar muscles are also frequently affected, leading to varying combination of facial paresis, dysarthria, and dysphagia. Ptosis is common, but pupils are never affected. Limb muscle involvement may vary from very isolated weakness to generalized weakness or fatigue. Myasthenia should also be considered in any patient who cannot be weaned from ventilator support after otherwise uncomplicated surgical procedure. Approximately 15 to 20% of myasthenic have only ocular and eye involvement. Now, how to detect patient is in crisis. Patient with definitive diagnosis of myasthenia gravis that complain of working weakness and shortness of breath need to be assessed for dysphagia, stridor, and adequacy of ventilation. During the examination, the respiratory pattern requires assessment. Rapid shallow breathing indicates respiratory muscle fatigue. Diaphragmatic function is assessed by observation of abdominal movement during the respiratory cycle. With severe weakness, the paradoxical respiratory pattern develops with inward movement of the abdomen during inspiration. The strength of neck muscle correlates with the diaphragmatic strength, and the weakness of this muscle should alert the clinician to possible respiratory compromise. The simple way to evaluate a ventilatory result is by asking the patient to count from 1 to 25 in a single breath. Patients with the significant limitation should undergo measures of respiratory parameters. Assessment of the oropharyngeal muscle begins with the inquiries of difficulty swallowing, episode of choking or coughing while a weight gurgling voice or stridor may indicate the need for intubation for airway protection. Swallowing may be tested outside by observing the patient swallow 3 ounces of water and monitoring for coughing and choking. However, caution should be taken in performing this assessment, and it need not to be done in patients with clear signs of oropharyngeal weakness. Patient may present with worsening of respiratory status because of vocal cord paralysis. In this patient, the flexible laryngoscopy loop should be performed. The finding of vocal cords in adapted position should alert the physician for possible need for cricothyrotomy in the cases that conventional endotracheal intubation is not feasible. The respiratory status of patient at risk for myasthenia crisis should be monitored closely. Bedside measurement of forced vital capacity, that is normal, is more than 60 ml per kg, and the measurement of negative inspiratory force, normal is more than 70 centimeter of water. Then positive expiratory force, normal is more than 100, should be done serially. ABG are also important. Pulse oximetry is not substitute for this measurement. Blood gas assessment are abnormal, with showing hypoxia and hypercarbia with advanced respiratory dysfunction. Patient may have normal oxygenation by pulse oximetry, while arterial blood gas show developing hypercarbia, which is a sign of impending respiratory arrest. Volume of functional velocity less than 1 liter, then less than 50 ml per body weight, negative inspiratory force less than 20, peak expiratory force less than 40. These are the indicators of the intubation. Early MV is preferable to prevent early mechanical ventilation is preferable to prevent worsening atelectasis. Patient with the low functional volume capacity but not to the level to warrant prompt intubation, and those with independent predictor of mechanical ventilation should be admitted to intensive care unit for serial measurement of spirometry parameters. Cardiac arrhythmias are common among patients with myasthenia crisis and are additional reason for intensive care monitoring of the patient with myasthenia crisis and evidence of impending myasthenia crisis. Now regarding differential diagnosis, acute intermittent porphyria, asymmetric limb weakness progressing to the quadriplegia after several attacks. Second one is botulism, nausea and vomiting preceding muscle weakness. Blurred vision, dysphagia, dysarthria, descending muscle paralysis, dilated pupils, dry mouth, constipation, and urinary retention. Third one is ICU-acquired weakness, that is critical illness map. Patient with the COPD and asthma requiring mechanical ventilation, use of neuromuscular blockers and corticosteroid. Patient with sepsis, critical systemic illness, and transplant patient. Then fourth one is electrolyte imbalance, in which patient will present as generalized muscle weakness, cardiac arrhythmias with or without rhabdomyolysis. Fifth one is GBS, which is preceded by upper respiratory and gastrointestinal infection, ascending paralysis and areflexia. Sixth one is Lambert-Eaton myasthenic syndrome, which is present as symmetrical proximal muscle weakness, hypoactive absent deep tendon reflexes, dry mouth, blurred vision, and orthostatic hypotension. Then seventh one is lead poisoning. It present as pure motor weakness, initially of extensor muscle, fasciculation, abdominal pain, constipation, anemia, renal failure, motor neuron disease weakness, wasting, and fasciculation. Then eighth one is organophosphate poisoning, exposure to insecticide, petroleum activity additives, modifiers of plastic, followed by acute cholinergic crisis, which manifest as muscle weakness, meiosis, and abdominal cramp. Ninth one is polymyositis, which manifests as proximal symmetrical muscle weakness and elevated creatinine kinase. Then tenth one is prolonged neuromuscular blocking, patient with impaired renal and hepatic failure, continuous neuromuscular blocking agent. Now the diagnostic studies. The diagnosis of myasthenia gravis is clinically suggested in patients who present with chronic ocular, bulbar, and appendicular weakness, variable over time with preservation of normal sensation and reflexes. Myasthenia gravis should always be considered in differential diagnosis of isolated ocular and bulbar weakness. Again, prominent muscle fatigability and temporal fluctuation are key features of the disease. Normal pupils, normal sensation, normal reflexes are to be expected and are helpful in diagnosing myasthenia gravis when coincident with acute and subacute paralytic illness. Now, regarding endrophonium test, it is a fast, short-acting parenteral anticholinergic inhibitor. It reaches the peak effect within 1 minute after intravenous injection and persists to some myasthenic weakness typically improves transiently after administration of 4 to 10 mg. The endrophonium test may be blinded with drug or normal saline being injected. Whether drug or placebo, 0.2 ml test dose is given to screen for excessive cholinergic side effects such as cardiac arrhythmia and gastrointestinal side effects. A resuscitation path is already available with known cardiac disease and elderly patients warrant electrographic monitoring. Interpretation of the test depends upon identifying and observing unequivocal baseline muscular deficit that can be increased following the injection of edrofen. Process and ophthalmotherapy, if present, are semi-quantifiable and well suited. If respiratory compromise maximum respiratory pressure. As a general rule, positive responses are dramatic. If there is any doubt about the positivity of the test, it should be considered negative. False positive adrenaline tests are quite rare. False negative are. Now regarding serological tests, antibody to acetylcholine receptor, 85% myasthenic may have detectable serum antibodies which bind to acetylcholine receptor. The sensitivity drops to 70% in those with purely ocular myasthenia. The presence of antibodies is strong indication of the disease. It correlates poorly with the severity of disease or clinical response to the therapy. If test is normal, it doesn't exclude the diagnosis, especially patients presenting with predominantly ocular symptoms and signs. These antibodies have also been found in small percentage of patients with Lambert-Eaton myasthenia gravis, then patient with autoimmune liver disease, patients with lung cancer without neurological disease. Now, antibody again directed against muscle. 30% to 70% may have antibodies directed against muscle specific tyrosine kinase an enzyme that catalyzes acetylcholine receptor agglutination in the formation of neuromuscular junction. Musk antibodies may reduce acetylcholine receptor clustering and impair neuromuscular transmission. Patients who have antibodies to Musk are young women, prominent bulbar involvement, neck and respiratory muscle weakness. It is indication of severe disease requiring immunosuppressive therapy and high frequency of respiratory crisis. Low density lipoprotein receptor. 10% of patients with generalized myasthenia gravis do not have detectable antibodies to acetylcholine receptor and muscle-specific kinase. Patients with thymoma and in those with late-onset myasthenia antibodies that react with muscle protein titin and ryanodine receptor. They may help in detection and recurrence of thymoma. They tend to be associated with more severe disease and may help in prognostication. Myasthenic also have increased incidence of other autoantibodies, including antithyroid antibody, antiparietal cell antibody, and antinuclear antibodies. Routine testing for these antibodies are not recommended. Now, the next test is electromyographic studies. Electromyographic hallmark of myasthenia gravis is decrement in amplitude of muscle potential seen after exercise or slow repetitive nerve stimulation. The decremental should be at least 10% and preferably 15% removed. Routine motor and sensory conduction studies are normal. The more severely affected patient is more likely to show decremental response. So this figure is showing 2 Hz repetitive nerve stimulation of the median nerve, demonstrating the significant amplitude decrement peaking at 25% on fourth wave of the trend. Note that the greatest absolute decremental of 14% is observed between first and second wave, typical of decremental pattern seen on the slow rates of repetitive nerve stimulation. General care in crisis. Identified trigger should be removed and corrected. All patients should undergo extensive evaluation for infection, including culture of the sputum, urine, and blood, as well as other sites as clinically indicated. Empiric use of antibiotic need to be carefully tailored to the clinical situation because of the potential for some antibiotic to further impair neuromuscular transmission further, as well as development of bacterial resistance. Avoidance of unnecessarily use of antibiotics is further emphasized by observation that C. diff colitis complicates the prolonged crisis. Nutritional assessment need to be made early in the course of myasthenia crisis. The determination is made for necessity of short-term nasogastric tube feeding, peripheral hyperalienation, gastrotomy tube with expectation that weakness may not resolve quickly. Electrolyte imbalance will compromise neuromuscular function and close monitoring with appropriate correction is required. Intermittent positive pressure breathing may be useful in preventing development of atelectasis, and if patient is already intubated or with respiratory tract infection, aggressive pulmonary toilet is necessary. Deep vein thrombosis prophylaxis measure should be undertaken with use of compression stocking, sequential compression devices in subcutaneous heparin. Coagulation status may be deranged from heparin use when plasma exchange is performed, and intravenous immunoglobulin therapy may predispose to hypercoagulation. Gastrointestinal prophylaxis is given either with histamine receptor blocker or proton pump inhibitor to prevent stress ulcer and gastrointestinal bleeding. Psychological support for the patient and family is also important, with emphasis on the ultimate ability to return most patients to an excellent functional level. Ventilatory management. Non-invasive bilevel positive patient ventilation is used for patients with chronic ventilatory insufficiency caused by neuromuscular disorders like muscular dystrophy, amyotrophic lateral sclerosis, and spinal muscular atrophy. It has been shown to be useful in patients with acute respiratory insufficiency caused by disorders like myasthenia gravis. In one series, endotracheal intubation during episode of myasthenia crisis was successfully avoided in 70% of trials. In this series, the presence of hypercarbia predicted bypass failure and need for intubation. The emergency neurological support or life support module for acute non-traumatic weakness recommended a trial of non-invasive positive ventilation as temporizing measure in patients with myasthenia gravis exacerbation who are expected to recover quickly and in whom immunotherapy can be instituted promptly. However, patients with severe ventilatory impairment and bulbar dysfunction should be excluded from the trial of NI. Once the decision for mechanical ventilation is made, rapid sequence intubation should be performed. This entails the backmasking the patient to obtain arterial oxygen saturation of greater than 97%. Administration of free-running intravenous normal saline, continuous blood pressure monitoring, and bolus infusion of sedative medication, usually etominet at 0.3, 0.2 to 0.3 mg per kg. If short-acting muscle relaxants are necessary, preferably they are to be avoided. Non-depolarizing agents like vecuronium should be used. Oral intubation should be undertaken whenever possible. Once the patient is intubated, the mode of ventilation needs to be chosen, but there is no perfect selection. Assist control and synchronized intermittent mandatory ventilation are commonly used, each one with its advantages and disadvantages. Muscle fatigability with the weakness and poor lung expansibility are main determinant in the development of myasthenia crisis. The initial objective of mechanical ventilation. It should be to promote rest and expand the lung. It was thought that as long as patient does not have primary lung disease compromising lung compliance, large tidal volume, that is 50 ml per kg, combined with lower rate to maintain normal minute ventilation. With positive end expiratory pressure at level of 5 to 15 mmHg could be used, providing the peak airway pressure are maintained with acceptable level, that is less than 40. However, literature suggested that smaller tidal volume, that is 6 to 8 ml per kg of idle body weight, with faster respiratory rate, that is 12 to 16 breaths per minute, should be used to avoid lung injury, adding intermittent size, that is 1.5 into tidal volume 3 to 4 times every hour to avoid atelectasis. Such a strategy has been called lung protective ventilation, which should achieve lung plateau pressure less than 30, allowing some permissive hypercapnia. Patients require continuous monitoring of end tidal CO2 to adjust respiratory rate to level as close to normal as possible to avoid significant acid-base derangements. Now, ventilator weaning. Several parameters may be helpful in when to initiate weaning from mechanical ventilator. So, if functional volume capacity is more than 50 ml per kg, negative inspiratory fraction less than 30, peak expiratory pressure force more than 40, and minute ventilation less than 15 ml per minute, the other general condition should be satisfied before weaning is attempted. That is, the patient need to be adequately oxygenated with PO2 of more than 60, with FiO2 of 40 and P less than 5. The patient also need to have intact respiratory drive. Uh, uh, that is, in patient with myasthenia gravis, respiratory drive is found to be impaired and is able to protect their airways and have adequate coverage. The hemodynamic status should be stable. Electrolyte levels are normal and nutritional status should be adequate. The patient should be free of infection or other significant medical complication. The need for respiratory suction should be less than 2 to 3 hours. Now, the treatment of neuromuscular dysfunction. Therapies may be divided into those that improve strength rapidly with short duration of action and those that improve strength slowly with more permanent response. In the first category, there are acetylcholine receptor inhibitors, plasmapheresis, and intravenous immunoglobulin. The second category comprise the immunosuppressive agents such as corticosteroid, azathioprine, cyclophosphamide, cyclosporine, mycophenolate, and tacrolimus. The latter are not used in rescuing patients from myasthenia crisis, but in long-term management. The role of corticosteroids are controversial. The oral corticosteroid dosing regimen and long-term prognosis. So this is the research paper which was published on oral corticosteroid. That is the objective was the oral corticosteroid to determine the oral corticosteroid dosing regimen and long-term prognosis in generalized myasthenia gravis. So they examine the correlation between the dosing regimen of prednisolone and achievement of minimal manifestation of status or better on prednisolone less than 5 mg per day lasting more than 6 hours. So the conclusion was low dose prednisolone regimen with early combination of other treatment option may ensure earlier achievement of treatment target in generalized myasthenia gravis. Cholinesterase inhibitor provides symptomatic improvement by means of decreasing the degradation of acetylcholine at neuromuscular junction. The continuous infusion of pyridostigmine is reported as an effective treatment in myasthenia crisis compared to plasmapheresis as measured by mortality, duration of ventilation, and outcome. Its use has been defended especially when myasthenia crisis is triggered by infection. However, it is common practice to discontinue this agent in mechanically ventilated patients due to propensity for promoting excess respiratory secretion in mucus plug. Another concern is the reported occurrence of cardiac arrhythmia in myasthenia crisis patients, including those receiving intravenous pyridostigmine. Cholinergic inhibitors could increase cholinergic activity at cardiac muscarinic synapses, leading to arrhythmia. This is the paper published in the Neuropathical Care Society demonstrating the role of acetylcholine esterase inhibitor in myasthenia crisis. And the conclusion was in places where IVIG or Plex is not available, continuous infusion of pyridostigmine and neostigmine may be used with or without other co-intervention, provided that the patient is admitted in intensive care unit and airway has been secured adequately. Caution should be observed in using acetylcholinesterase inhibitor because of possible cardiac complications. Legs has traditionally been preferred treatment in managing myasthenia gravis, with reported efficacy of 75%. Its mechanism of action is related to the removal of circulating factors in addition to acetylcholine receptor agonist. There is no standard protocol for Plex. The usual regimen is exchange of 1 to 1.5 plasma volume every day or every other day for 5 to 6. Clinical improvement may be seen as early as 24 hours. In most patients, first effect appear after 2 to 3 sessions of the Plex. Some patients may have initial worsening thought to be due to reduction in the plasma concentration of cholinesterase. The duration of the effect is usually less than 10 weeks if other immunosuppressive treatment is not instituted. The most frequent complications of Plex are hypotension, electrolyte imbalance, depletion of clotting factors, and thrombocytopenia. Obtaining vascular access may at times may be difficult and may be complicated by pneumothorax, thrombosis, and infection. When large volume plasma is removed, intravascular volume should be replaced with albumin in saline solution. Any electrolyte imbalances should be corrected to prevent exacerbating weakness. The coagulopathy is usually mild but should be kept in mind when utilizing subcutaneous heparin for deep venous thrombosis prophylaxis. Reducing antihypertensive drug dosages and administering intravenous fluid before procedure may avoid hypotension. In most patients, first effect appears after 2 to 3 sessions of the plague. Some patients may have initial worsening, possibly due to reduction in plasma concentration of cholinesterase. The duration of effect is usually less than 10 weeks if other immunosuppressive treatment is not necessary. The most frequent complication of the plaques are hypotension, electrolyte imbalance, and depletion of clotting factor thrombocytopenia. Obtaining vascular access at times is difficult and may be complicated by pneumothorax thrombosis and infection. When large volume of plasma is removed, intravascular volume should be replaced with albumin. Any electrolyte balance should be corrected. Coagulopathy is usually mild but should be kept in mind when utilizing subcutaneous heparin for delivery. Reducing antihypertensive drug dosage and administering intravenous fluid before procedure may avoid hypotension. Another option for specific treatment for myasthenia crisis is IVIG. The standard dose consists of 400 mg per kg per day of IVIG for 5 days. Response to IVIG is usually observed 5 days after treatment initial. There is a fungal consequences that IVIG may be as effective as Plex. However, IVIG may be better choice in patients with hemodynamic instability, vascular access problem, or with poor response to Plex. Adverse effects occur in fewer than 10% of patients and most commonly include headache, chills, fever, fluid overload, and rarely renal failure. Anaphylaxis may occur due to IVIG component in patients with IgA deficiency. IgA levels and baseline renal function should be obtained before treatment is initiated. IVIG and Plex are equally effective in treatment of impending or manifest myasthenia crisis. Choice between two strategies depend upon the patient's comorbidities. For example, Plex cannot be used in sepsis, and IVIG is contraindicated in hypercoagulable state, renal failure, and hypersensitivity to the immunity. The use of preoperative Plex is advocated in patients with generalized myasthenia gravis and preoperative symptoms of oropharyngeal and respiratory disease, or in patients with the symptoms controlled by the use of cholinergic inhibitor in order to prevent delayed extubation and reintention. IVIG has also been used preoperatively, but the variability in reaching maximum response should be kept in mind. Next treatment line is thymectomy. Thymectomy is always indicated in patients with thymoma because of its malignant potential. Thymectomy has been mainstay of the treatment for non-thymatomatous myasthenia gravis for over 50 years. However, randomized trial of thymectomy versus medical treatment are lacking. Thymectomy within first 3 years of diagnosis may lead to better response. The procedure is commonly restricted to patients under the age of 60 to 65 years because older patients have usually atrophic thymus. Anti-mask antibody positive patients tend to have poor response, probably explained by lack of typical thymus pathology in this patient. There is controversy as to whether or minority of seronegative myasthenia gravis patients benefit from thymus. This is the journal presented in the New England Journal of Medicine. So, it was a randomized trial of thymectomy in myasthenia gravis. So, the conclusion was if thymectomy improved the clinical outcome over 3 years of over 3 year period in patient with non-thymotomatous myasthenia gravis. Thank you.